Good morning, respected Emeritus Chairperson, Mahatma Gandhi University of Medical Sciences and Technology, Dr. M.L. Swankar sir, Chairperson cum Chancellor, Dr. Vikas Chandra Swarankar, Vice Chancellor Dr. Achal Gulati, Pro Vice Chancellor Dr. V.K. Kapoor, Principal, Mahatma Gandhi Medical College, Dr. N.D. Soni, Senior Faculty members, dear colleagues and dear students. I welcome you all to the 11th undergraduate combined rounds of Mahatma Gandhi Medical College and Hospital. Today's our topic is asthma. And as this is a vast and very important topic, we have divided it into two parts. Part 1 will consist of anatomy, physiology, pathology and pharmacological aspects of asthma, and part 2 will deal with clinical features, management and prevention of asthma. Presentations are prepared by our undergraduate students under the guidance of faculty of the particular subject and under the guidance of head of the departments of the subject concerned, and then presented by undergraduate students, as you all know. Today's chairpersons are Dr. Sanjay Chaudhary, Professor and Head, Department of Forensic Medicine, Mahatma Gandhi Medical College, and Dr. Anusha Vora, Professor and Head, Department of Pharmacology, Mahatma Gandhi Medical College. Now it's over to Dr. Mahesh Mishra. He is a renowned pulmonologist, Professor and Head, Respiratory Medicine, Mahatma Gandhi Medical College, for his expert view on asthma. We welcome Dr. Mahesh Mishra.
Very good morning. Respected Emeritus Chairperson, Pro Vice Chancellor sir, Medical Director sir. Today's topic is asthma. Why is this is important? As we all know, India is a hub of the non-communicable disease. Asthma is the only non-communicable disease which manifests both in childhood as well as in adults. Asthma is a global serious health problem, having around 300 million people affected globally from asthma. Our country contributes around 34 million of our country affected from asthma. So we are contributing around 13% of the asthma population globally. But what is disheartening, every year there is 5 lakh deaths happens due to asthma. We are contributing 50% of the asthma death. 50% of asthma death happens globally due to asthma. Why it is so? Why we are contributing, despite of having 10% of asthma, we are contributing 50% death? This is mainly because of lack of asthma education. Asthma education in both in doctors and both in patients. What is the lack of asthma education in doctors? That not able to diagnose the asthma in time, not able to give treatment as per protocol. And what is as part of patient, they are not they are not ready to accept that I have asthma, my kid have asthma. Parents often ask, अभी से अस्थमा कैसे हो गया इसको, अभी तो बहुत छोटा है. Second part, they are not ready to accept asthma medication. There are lot of myths about asthma medication. Asthma medication, we all know that inhaled corticosteroid is the main step of the asthma treatment. And there are lot of myths about the asthma treatment. साहब ये पाउडर उसमें जम जाएगा, ये फेफड़े खराब हो जाएंगे हमारे, अभी से फेफड़े में दवाई लेंगे तो हमारा क्या होगा. There are lot of myths about asthma medications. तो अस्थमा बेसिकली डिफाइन एज ए हेट्रोजेनस ग्रुप ऑफ डिसऑर्डर्स. You keep each word very important. Heterogeneous group of disorders that is characterized by shortness of breath, cough, chest tightness, wheezing in variable intensity and combined with the variable airflow limitations. So this each word of this definition is important. Heterogeneous means group of disease. Variable means not constant. Patient might have symptom morning, may don't have symptom in the evening. Airflow limitation, variable airflow limitation means the lung function might have normal when presented to you, might have abnormal when presented to you. So good clinical history, paramount importance in the asthma. What is good clinical history? Because good clinical, why good clinical history is essential? Because what is happens in the respiratory disease, all respiratory diseases present with the same symptom, same 4 or 5 symptoms: fever, cough, expectoration, hemoptysis, chest pain. These are 4 or 5 cardinal symptoms. What is respiratory disease? But each disease has certain specific symptoms. There is thin line. There is thin line between the various symptoms. So good clinical history. How to take good clinical history? Good clinical history is a very important part while we dealing with the patient of respiratory disease. Just for asthma, we have to take onset of symptom. What are the time of onset symptom? What is the night symptoms? And how it respond to the treatment? How it respond to the treatment? Most important part when we deal with the shortness of breath. Dyspnea in classically in respiratory disease is not related to exertion. Not related to exertion. If dyspnea related to exertion, it means we are dealing with something else. Dyspnea related to exertion in respiratory disease typically occurs 14-15 minutes after exertion, or typically relieved after 1 to 2 hours of stopping exertion. While dyspnea in exertional disease due to cardiac pathology, immediately patient start exertion and immediately relieve when patient stop exertion. As far as diagnosis is concerned, good clinical history combined with the pulmonary function test. Pulmonary function test is accessible at all good laboratories. We can easily identify the good clinical history combined with the function test. If pulmonary function is not available, then very simple tool, peak expiratory flow rate can be used for the diagnosis of bronchial asthma. As far as treatment is concerned, standard treatment is inhaled corticosteroid. Inhaled corticosteroid. And there are a lot of newer advancement, newer development in the disease pattern, like biologics have been developed for the treatment, but they are all on add-on therapy. Indian traditional treatment also help, but they are all supportive treatment. They are all supportive treatment. Last 30-40 years, awareness upon physician and patient has increased, but still lot of work to be done. And I hope this UGCR will help, especially for undergraduate students, to read how to make diagnosis of asthma and how to treat asthma, and help in better understanding of the nature of disease and its treatment. Thank you.
A very warm good morning to respected dignitaries members, esteemed faculty members, and my dear fellow colleagues. Under the guidance of Dr. Pankaj Kumar Singh Sir, Professor and Head of the Department of Anatomy, and under the moderatorship of Dr. Runjun Vijayvargiya Ma'am, Assistant Professor of the Department, along with Ayushi Joshi, Divya Yadav, Kanishka Gehlot, Tanvi Sankar, I, Nikhil Badesara of MBBS Second Professional, is here to present on embryology and anatomy of respiratory pathway. Let's break up the overview. We have the embryology of respiratory tract, the upper respiratory tract, the lower respiratory tract, the blood supply and innervation, and the clinical correlations. Before moving towards the anatomy of respiratory pathway, let's have a look on what asthma is. Asthma is bronchial smooth muscle hypertrophy, which is characterized by the bronchospasm with the increased mucus secretion. Begins with the trachea and the bronchi. There is a presence of the C-shaped cartilaginous rings, and in case of the bronchi, there are the cartilaginous plates are present, which are surrounded by the smooth muscles, while in the case of the bronchioles, these cartilaginous rings are the absent and are surrounded by the irregular boundaries of the smooth muscles, which makes them more prone to the spasmodic conditions as like in the asthma. The respiratory pathway begins with the nose, followed by the nasal cavity, leads into the pharynx, the larynx, trachea, bronchi, bronchioles, and up to the alveoli. This whole pathway is divided into the upper respiratory tract, from the nasal cavity or nose to the larynx, or the lower respiratory tract from trachea to the alveoli. The development of the respiratory pathway begins with the formation of the primitive gut tube, which is precursor to the gastrointestinal tube, in the 4th week of the intrauterine life. From this primitive gut tube, there is a development of a single laryngotracheal tube, which forms the tracheal bud or the respiratory diverticulum, which bifurcates into the primary bronchi. This respiratory diverticulum grows, elongates, and separated from the esophagus through the tracheoesophageal septum. This tracheoesophageal septum forms the trachea on the ventral side and the esophagus on the dorsal side. These primary bronchi further divides into the secondary bronchi or the lobar branches, which supply each lobe of the lungs. Further divisions of the lobar branches is seen as the segmental branches or the tertiary bronchi, which supplies the bronchopulmonary segment of the lung. Now comes to the developmental stages of the lung. The branching of the bronchioles begins in the 6th to 15th week of the intrauterine life, as seen in the pseudoglandular stage. After this, the alveolar duct and the air sac formation occurs in the secular stage, and the secondary septation and increase in the number of alveoli is seen from the birth up to the 8 to 10 years of the life. Normally, the tracheoesophageal septum divides into the trachea and the esophagus, but 1 in 4500 of the birth, there is a connection between the trachea and the esophagus, leads to the formation of the tracheoesophageal fistula. The anatomy of the upper respiratory tract. The upper respiratory tract begins with the nose, opens into the nasal cavity. The nasal cavity opens into the posterior nasal aperture of the nasopharynx. The nasopharynx leads into the laryngopharynx, which is a part of the pharynx. The laryngopharynx then opens into the larynx and then continues in the lower respiratory tract with the trachea. The nose consists of the external nose and the nasal cavity. The nasal cavity is divided into the 3 regions. The vestibule region, which is the anterior most part, which is lined by the skin and the vibrissae, which are the hair cells. The respiratory region, which is lined by the pseudostratified ciliated columnar epithelium, and the olfactory region, which has the neurons for the smell. The bony projection in the nasal cavity are known as the concas, the superior and the nasal concha, the middle nasal concha and the inferior nasal concha. The superior and middle nasal concha are the part of the ethmoidal bone, while the inferior nasal concha is itself a separate bone. Below each concha there is the meatus present for the drainage of the sinuses. These paranasal air sinuses are the air-filled spaces divided into the anterior group and the posterior group. The anterior group consists of the frontal, the maxillary, anterior ethmoidal and the middle ethmoidal air sinuses which drains into the middle meatus, and the posterior group, the posterior ethmoidal and the sphenoidal air sinuses drains into the superior meatus of the nasal cavity. Now comes to the pharynx as discussed earlier. Pharynx is subdivided into the nasopharynx, the part which is behind the nasal cavity, the oropharynx which is behind the mouth, and the laryngopharynx, the part behind the larynx. The pharynx acts as a common channel for the deglutition and respiration. The pharynx continues into the larynx, which is the organ of phonation, and acts as a sphincter or the inlet to the trachea. It is about the 12 to 14 centimeter long and it consists of the 3 unpaired cartilages and 3 paired cartilages. The 3 unpaired ones are the thyroid cartilage, the cricoid and the epiglottis, while the paired cartilages are the arytenoid, corniculate and the cuneiform cartilages. The larynx consists of the vocal cords, which are the muscular bands or the muscular tissue which helps in the production of the sound. Now comes to the lower respiratory tract. The lower respiratory tract begins with the trachea, which further divides into the two primary bronchi, the left primary bronchi and the right primary bronchi. These primary bronchi give rise to the secondary or the lobar bronchi, which supply the lobes of the each lung, and these lobar branches are further divided into the segmental branches or the tertiary branches. These tertiary branches give rise to the terminal bronchioles, the respiratory bronchioles, and finally opens into the alveolar duct, then alveolar sac. The trachea is located at the level of C6 to T5. It is about the 10 to 12 centimeter long and is covered by the C-shaped cartilaginous ring lined with the ciliated pseudostratified epithelium, which helps in the trapping of the foreign particles. The right primary bronchi is shorter, wider and more vertical than the left one, while the right lung has the 3 secondary bronchi, each for the 3 lobes of the right lung, while the left one has the 2 secondary bronchi, each for the 2 lobes of the left lung, and the tertiary bronchi or the segmental bronchi supplies the bronchopulmonary segment of the lung. The bronchioles arise from the bronchi are the terminal bronchioles and the respiratory bronchioles. The respiratory bronchioles has role in the respiratory and the gaseous exchange process. The alveoli are tiny air sacs which present in the lungs and forms the structure and functional unit of the lung. The alveolar duct are the thin-walled connection between the respiratory bronchioles and the alveolar sac, which opens into the alveolar sac, which are the cluster of the alveoli. This whole alveoli is consist of the 2 types of cell, the type 1 cell for the gaseous exchange process and type 2 cell which secrete the surfactant and release surface tension, which prevent it from the alveolar collapsing. The whole alveoli is supplied or surrounded by the rich pulmonary capillaries, helpful in the blood conduction or the respiratory process. Now comes to the bronchopulmonary segments. The bronchopulmonary segments are the anatomical and functional subdivisions of the lung. We have the superior lobe, middle lobe and inferior lobe in the right lung, and superior lobe and inferior lobe in the left lung. The superior lobe of the left lung is divided into the 4 bronchopulmonary segments, while the superior lobe of the right lung is divided into the 3 bronchopulmonary segments, that are the apical, the anterior and the posterior segments, while the left one are the apicoposterior, the anterior segment, the superior lingula and the inferior lingula. The inferior lobe of the both lung is divided into the three segments: the anterior basal, the posterior basal, and the lateral basal segments, while the middle lobe of the right lung is divided into the medial and the lateral segments. The blood supply to the respiratory pathway is carried out by the bronchial arteries and the pulmonary arteries. The bronchial arteries are the branch from the thoracic aorta which supply the oxygenated blood to the alveoli, while the pulmonary arteries carries the deoxygenated blood from the alveoli. The venous drainage is carried out by the bronchial veins, which carries the deoxygenated blood, and the pulmonary veins, which carried out the oxygenated blood. The nerve supply and the innervation is carried out by the sympathetic division and the parasympathetic division. The sympathetic division arises from the T2 to T5 spinal segment and causes bronchodilation and decreased mucus secretion, while the parasympathetic division arises from the vagus nerve, causes the bronchoconstriction and increased mucus secretion. Comes to the clinical correlation. Asthma, as discussed earlier, is the narrowing in the bronchial diameter, and due to the increased mucus secretion or tightened smooth muscle is symptomized with the difficulty in the breathing, chest pain or the tightness, shortness of breathing, and the wheezing. Now, I would like to call upon Ayushi Joshi from Physiology Department.
Good morning, everyone, respected dignitaries, esteemed faculty members, seniors, and dear colleagues. I am Ayushi Joshi from MBBS first year, and I, along with my team members, Diksha Jatolia, Meher Mathur, Shlagha Singh, and Tarushi Sharma, are here to represent the Department of Physiology under the guidance of Dr. Aparna ma'am, our HOD, and under the moderatorship of Dr. Rosie ma'am and Dr. Himanshu sir. So the topic of our today's discussion is asthma and the physiology regarding the same. So these are the learning objectives for your reference. Let's begin with talking about bronchioles. So bronchioles are the smallest conducting airways of the lungs, and these bronchioles, they lack cartilages and are made up of the smooth muscle cells. And because of these smooth muscle cells, they are susceptible to contraction as seen in asthma. Now, bronchioles are very imperative when one is talking about the respiratory tree. So now we have this classification called the Weibel's classification, where we are classifying the respiratory tree into different zones, which was given in 1963 by a Swiss anatomist. Now we can see in the diagram on the left-hand side, we assume that the trachea represents the 0th generation. From the 1st to the 16th generation, we see that there is the conducting zone. From the 17th to the 23rd generation, we have the respiratory zone. So now the conducting zone, it is actually involved in conducting the air which we inhale and humidifying the air. It is strictly not involved in the gaseous exchange. Now the terminal bronchioles, they mark the ending of the conducting zone. The respiratory zone, which starts with the respiratory bronchioles, contains the alveoli and the alveolar sac, with the alveolar sac representing the 23rd generation. So this respiratory zone is actually involved in the gaseous exchange which is taking place. So we can better understand this from the diagram. So here on the left hand side, we see that we have the terminal bronchioles representing the 16th generation. We have the trachea representing the 0th generation, as well as the alveolar sac, which is representing the 23rd generation. Now that we know that respiratory zone is actually involved in gaseous exchange, we need to understand that respiratory alveolar membrane is the place where the actual gaseous exchange is taking place. Now the respiratory membrane, it is a thin barrier that enables the gaseous exchange between the alveoli and the pulmonary capillaries. Now it is quite thin, which is about 0.5 micrometers, but the surface area is gargantuan, which is 70 to 100 meters square. Now both of these factors actually help to facilitate easy diffusion of the gas from the environment that is present in the alveoli to the pulmonary capillaries. There are three main components of the alveolar membrane. First is the alveolar epithelium, consisting of two types of pneumocytes. Type 1, which is involved in the gaseous exchange, and type 2, which is involved in the surfactant production. We can see in the diagram it is written type 1 alveolar cells and type 2 alveolar cells, which is one and the same thing. Now, what is the need for this surfactant production? So, the alveoli, they have the tendency to collapse all the time. Why? Because the interior side of the alveoli has a thin layer of water. And because of this air-water interface, we see that surface tension is caused. Now, this surface tension actually wants to collapse the lungs, which is prevented by the surfactants. Then we have the basement membrane. We can see in the diagram also there's this oval part which has been labeled. Now, this oval part is representing the entirety of the respiratory membrane. We can see that there is a red layer and then there is this pink layer. So, in between these two basement membranes, which is actually acting as a junction between the two, we see that the interstitial space is sandwiched between the basement membrane of the alveolar epithelium as well as the third component of the alveolar membrane. So now we have the pulmonary endothelium where the red blood cells are present, and these red blood cells are involved in the gaseous exchange. For example, the oxygen we have inhaled, the oxygen comes, and now this oxygen is going to bind with the oxygen binding pigment, that is hemoglobin. We'll be able to understand this better through this animation. Here what we see is that this is the alveoli, this is the gas, and now through this respiratory membrane it is binding to the RBC. Now, what exactly is the mechanism of breathing? Now we have understood that respiration is taking place with the help of respiratory membrane. Now, respiration mechanism involves the gaseous exchange between the alveoli and the blood through inhalation and exhalation, which is again influenced by the pressure and the volume changes taking place. Now, it involves inspiration and expiration. So, the point of commonality between inspiration and expiration is the fact that the main muscle which is involved is the diaphragm. Now, talking about inspiration, we see that the diaphragm, what it does is, it contracts. Please refer to the diagram on the left-hand side. We see that the diaphragm contracts, becomes flattened, and increases the diameter in the vertical direction, while the accessory muscle, which is the external intercostal muscle, moves upwards and outwards and increases the diameter in the anterior-posterior direction. Now that the overall intrathoracic cavity volume has increased, the pressure is going to significantly decrease, and the pressure is the intrapleural pressure. So it is going to decrease to such an extent that it becomes less than the atmospheric pressure, so the air will gush inside the lungs. Exactly opposite thing is going to happen in expiration, where we see that first of all, expiration is a passive process until and unless some kind of pathology is involved. For example, in asthma, the exhalation is labored. Now, because the expiration is a passive process, we see that it mostly happens due to the lungs recoiling ability. Now, the diaphragm, it relaxes, becomes dome-shaped, thereby overall the intrathoracic volume has decreased. Now, the volume has decreased, so the pressure is going to increase. The intrapleural pressure becomes more than the atmospheric pressure, so the air, it actually moves out of the lungs. One point to note here is that when we are doing chest x-rays, typically the patient is asked to have a full inspiration. Now, talking about lung compliance. So, before going into the mathematical definition of the lung compliance, let's understand what lung compliance is. So, lung compliance refers to a person's lungs' ability to expand or stretch with the pressure variation being applied, which means unit change of volume with respect to unit change in pressure, which is why the formula comes out to be delta V by delta P. Now, compliance can be high and low. High compliance means that a person's lung is able to expand with the pressure variation, but we see that the work of breathing is overall reduced. But it is not always beneficial for the patient because it might affect the elastic recoilability of the lung. Now, the low compliance happens because the lung has become so stiff that the person is having a hard time stretching his lungs with the pressure variation we are applying. Now, the lung compliance, when we are talking about asthma, is generally normal, but when the person is suffering from severe asthmatic attacks, we see that it is mildly reduced. Now, on the left-hand side, we have this graph, which is representing the hysteresis. So, hysteresis loop shows us the differentiability in the path of the expiration and the inspiration. We see that the expiration is happening with the arrow being upwards. In this case, we see that the intrapleural pressure, which is on the x-axis, it is going into the negative direction, which means that they are expanding, the airways are expanding. While we see in the expiration case, it is going downwards, which means that it is going to the positive side, which means that they are narrowing. Now, the lung compliance, it directly affects our work of breathing. So what is work of breathing? So work of breathing refers to how much effort one has to apply in order to move the air in and out of his lungs. So it involves the muscular efforts to overcome the air resistance and the lungs elasticity. There are certain factors which affect them. First is the elastic resistance, which is the recoiling ability of the lungs and the chest wall, which contributes to about 65%. Then we have the airway resistance, which is actually the resistance faced by the bronchioles. It can be changed in their overall diameter or length due to some kind of pathology, which contributes to about 30%. Once we see that these are the two factors, there is a third factor called the tissue resistance, which is actually the friction faced by the lungs when they are moving. It is actually pretty infinitesimal when we are talking about the actual factors which are affecting, so it contributes to about 5%. We can see the graph on the left-hand side is showing us different work. So the green one, it is representing the inspiratory work, which is the efforts which a person has to overcome when he is inhaling. That is the airway resistance. We see that the expiratory work, which is the efforts which need to be done to overcome the expiratory, when we are expiratory phases going on, that is the airway resistance. But one might think that if expiration is a passive process, why do we have expiratory work? And the reason for that is because certain amount of air resistance, the elastic resistance is present, due to which we do require some amount of work when we are expiring. On the purple side, we see that there is the elastic work, which is again the recoiling ability of the chest wall and the lungs, which one needs to overcome. Now is the lung volume. So the lung volumes are of two types. We have a static lung volume and we have a dynamic lung volume. So static lung volume includes tidal volume, inspiratory reserve volume, expiratory reserve volume, and the residual volume. One thing to note here is that static lung volume is recorded when the air is not moving in and out of the lungs. That means it is not actually dependent on the time. So that is why its unit is only going to have ml. One thing to note here is that residual volume increases slightly when the patient is asthmatic. Because the patient is having a hard time exhaling the air, that's why some amount of air gets left inside the lungs. That's why the residual volume increases. Now we have the dynamic lung volume, which is dependent on the rate of the flow of air. That's why its unit is going to have ml per minute, which are of two types. We have the forced vital capacity and we have the forced expiratory work of 1 second. So the forced vital capacity, it represents the amount of air exhaled by a person during a full inspiration, while the forced expiratory work of 1 second represents the amount of air exhaled by a person in 1 second during a forceful expiration. Now both of these are very important when we're talking about the obstructive and the restrictive pathologies, because their ratio helps us to identify what the person is suffering from. So generally the standard ratio is 70 to 85%, but it decreases in the obstructive disease and increases in restrictive disease. One thing to note here is that the ratio is pretty ambiguous when we are talking about the restrictive disease. Because the restrictive disease, we see that the ratio might increase, it might remain normal, or it might decrease. First of all, why will it increase? It will increase because the FVC is going to increase. The FVC is going to decrease, while the FVC is also going to decrease, but not to that much extent. So that is why the overall ratio is going to increase. We see that it is going to remain normal. Why? Because the FVC as well as the FVV1, it is going to decrease, but proportionately. Now, because of the proportion, we see that the overall ratio is not much affected. We can see in the graph also, one thing to note here is that in the obstructive disease, the FV1 is significantly reduced, which means that exhaling ability of a person is intensely labored. One way to measure the static lung volumes is the spirometer. So on the right hand side, we have the manual spirometer, and on the left hand side, we have the manual spirometer. Now that we've talked about the normal physiology, how is asthma exactly affecting the normal physiology of our body? So first of all, asthma is a major non-communicable disease which is affecting all age groups. So according to the World Health Organization, it is defined by the inflammation and narrowing of the small airways in the lungs, which causes difficulty in expiration. So symptoms include coughing, wheezing. Wheezing means the rattling sound which comes when the person is exhaling. There is shortness of breath and chest tightness. So the person will feel as if someone has tied ropes around his chest and pulling from both the sides. Now we can see in the diagram also that the mucus plug, why is it caused? It is because of the increased airway resistance, which is caused by the bronchoconstriction, as well as the mucosal inflammation due to the hyperactivity of the submucosal cells. Now, how is asthma affecting the bronchioles? That is the question. First, we know that the bronchoconstriction is taking place, the inflammation and edema has been taking place, there is hyperactivity of the submucosal bronchioles, and because of this hyperactivity, mucus is going to surround the entirety of the bronchioles. And we see that in certain cases, when person is affected by severe asthma, these mucus plugs are coughed out by the patient. Now, how is it affecting the factors of work of breathing? First of all, the compliance is going to be low. Again, specifically when the person is affected by the severe asthma or during an asthmatic attack. There is increased airway resistance due to the bronchoconstriction, and overall, the work of breathing has increased, so the person will be fatigued after doing a strenuous exercise or any amount of effort which can be done by a normal person. So this is the pictorial representation of how the changes are taking place. In the first picture, we see that the bronchioles are healthy, they are normal. In the second one, we see that there is irritation as well as the swelling. So the mucus has surrounded the entirety of the circumference of the bronchioles. That's why air resistance has been increased. We have the obstructive and the restrictive pathology. So obstructive airway disease, first of all, means that the person is having a hard time exhaling the air. Restrictive airway disease is a person is having a hard time inhaling the air. Now, when we are talking about the obstructed airway disease, we see that the forced expiratory volume of 1 second is significantly reduced. FVC is also reduced, but not to that much extent. Now, the ratio is going to be less than 70%, and this ratio is suggestive of the fact that the expiration is labored. The mechanism by which it happens is the narrowed airway constriction. Now, examples include asthma as well as the COPD, which is the chronic obstructive pulmonary disease. In the respiratory airway disease, we see that the FV1 is reduced, but FVC is reduced to a very significant extent, because of which the overall ratio is either going to be normal or increased or slightly decreased. So its range is going to be about less than 80%. The mechanism by which it is taking place is the lung compliance is low. And the examples include the pulmonary fibrosis and the chest wall deformities like kyphoscoliosis. So here what is happening is that the lungs have become so stiff that the person is having a hard time stretching or expanding his lungs with the pressure variation, due to which we see that the lung compliance is reduced. So because the table can be a little obfuscating, we have this graph, and we see that the graph is able to help us understand what exactly is happening. So in the normal side, we see that the peak expiratory flow is normal. While on the obstructive side, we see that the peak expiratory flow is reduced. Why is it reduced? Because of the airway resistance. Inspiratory curve and the loop is also reduced, but not to so much extent, because the airway resistance is there, so person will have a hard time inhaling, but it won't be much significant when we are talking about the treatments. On the restrictive side, we see that the peak expiratory flow is normal, but it can be mildly reduced. But one point to note here is that the loop of the inspiration is significantly reduced. Person is having a stiff lung, so he'll face problems inhaling the air. So we can summarize the entirety of the presentation regarding the physiology using this video. So here we see that this is a normal bronchiole. Now the person is having a hard time exhaling. Now what is exactly happening in his lungs? Let's see. So air is going inside. Now these bronchioles, specifically the smooth muscle rings, they are going to remodel. Inflammation is going to take place, due to which increased mucus production. This is the normal one. And this is the inflamed one. So the symptoms, what are the symptoms? The symptoms is the chest tightness, coughing, wheezing, and overall shortness of breath. This is the bibliography. Thank you so much for your patient listening. May I now invite the presenter from the Department of Pathology, Aditya Mittal.
Ayushi, stay on. Good presentation. So what I'm going to say is not for you, it is for everyone. You are only the shoulder on which I am firing the gun. Go back to the slide showing 2 respirometers. Yes. So you said the picture on the left. Who's left?
So I'm talking about your left.
Yeah. So as a general rule, because you said right when you wanted to say left.
So sorry,
as a general rule, left and right is audience.
Yes.
If you want to be more clear, it is better to say the picture on your left. If I ask you a question, what does this spirometer show? I will say, what does the spirometer on my left or your right shows? That is one. Second was, every student should know how to generate a laser pointer on the screen. Because you were trying to point out something, you should know, every student should know how to generate. You know, right
Yes,
click and then
left
laser
click.
pointer.
Yes, sir.
Third, come to that slide where there are circles. So N has got separated from constrictio. So either you reduce the size of the font or you increase the size of the circle so that the word is in full. Last, yeah, stretch.
Yes, sir.
Yeah. So many other. And lastly, you said we don't do any work when we do some work when we expire.
Yes, sir.
It is not expire when we expirate. The
And
verb is inspirate and
and
expirate.
expire is
Otherwise,
death.
you will land up with the situation where doctor said inspire, patient inspired, doctor said expire, and the patient expired.
I'll try to make it more
Very good
streamlined.
presentation.
Thank you so much, sir.
So I think Dr. Kapoor is talking about pointer. When you have a laser pointer, there are some ethics to the use of the laser pointer. Can you give me your laser pointer, young man? The audience usually follows your point, right? So if you are doing too much of this, no, you're producing vertigo in your audience, right? So this is not to be done, okay? Suppose you want to highlight this, just just like this, right? And most of us do not have very steady hands. Like I have a little bit of tremor, not very much, but I do. So you should stabilize your hand. Either you can hook it in your pocket so that there is no tremor. Or on your podium, you could take a support of the side of the podium, right? Most importantly, and the problem which you did, that you kept the laser pointer on while you were speaking, right? So your pointer is over here, the audience is looking over there, and you're talking about something else. So short, quick flashes, highlighting, and just don't do this, right? आप देखो आप, if I want to talk about bronchoconstriction and I'm doing this versus I'm doing this, what feels better, right? Few small things applies to the young people who are beginning to make good presentations, also applies to lots and lots of seniors, and I see them going all over the place and confusing the audience, and it's not a nice thing to do.
But Ayushi, excellent presentation, beta. I'm proud of you.
A very good morning. A very good morning and a warm welcome to the respected dignitaries. A very good morning and a warm welcome to the respected dignitaries, esteemed faculty members, a very good morning to the respected dignitaries, esteemed faculty members and my fellow colleagues. Today, under the guidance of Dr. Manju Raghav ma'am, Professor and Head, Department of Pathology, and under the moderatorship of Dr. Neeraj Krishna Goyal sir, Assistant Professor, Department of Pathology, and alongside my colleagues Divyanshi Singh, Dhruv Jain, Ekta Arora, and Pragya Davi, I, Aditya Mittal, am here to present the topic, etiology and pathogenesis of asthma. The first thing that comes to mind when we talk about asthma are probably symptoms like wheezing, breathlessness, a feeling of chest tightness, and cough. Asthma is a heterogeneous disease, which means it has various etiologies. It is usually characterized by chronic airway inflammation and variable expiratory airflow obstruction. Based on its etiology, asthma is classified into 4 types. Atopic asthma is the most common type of asthma. Atopy, by definition, means genetic predisposition. It is usually characterized by allergen sensitization, and it subsequently results in IgE-mediated type 1 hypersensitivity reaction. The non-atopic form of asthma shows no allergen sensitization, and some theories suggest that it may be caused post-viral infections. It shows negative skin tests and normal IgE antibody levels. As we can see here in this diagram, it shows various steps to a skin allergy test. First, we mark a small area on the flexor aspect of the forearm. Then we apply a drop of the allergen for which the allergy is to be tested. We put a small prick there, and we wait for 15 to 20 minutes. If there is an allergic reaction in the small area, we can conclude for the skin allergy test to be positive for that particular allergen. Moving on to occupational asthma, it is usually caused due to environmental factors and irritants like chemical fumes, paint sprays, animal fur, etc. in jobs like chemical workers, paint sprayers, animal handlers, etc. Drug-induced asthma is mainly caused due to a class of drugs also known as non-steroidal anti-inflammatory drugs. Drugs like aspirin, which inhibit the enzyme cyclooxygenase, result in the abnormal prostaglandin metabolism, particularly prostaglandin E2. Asthma can also be classified based on its mechanism of action. Type 2 asthma here is mainly characterized by eosinophil recruitment and is mediated by the type 2 T helper cells, whereas non-type 2 asthma here is usually characterized by neutrophil recruitment and mediated by type 17 and type 1 T helper cells. Let's move on to the pathogenesis of asthma. Here is the normal airway of an individual, which we will be comparing to an airway of the asthmatic individual afterwards. Moving on to the mechanism underlying asthma. When the dendritic cells in our body are exposed to the allergens, they release certain mediators which activate the type 2 T helper cells. These type 2 T helper cells secrete mediators like interleukin 4, interleukin 5, and interleukin 13. The interleukins 4 and 13 in particular cause increased IgE antibody production, and the interleukin 13 causes increased mucus production. These IgE antibodies go and bind to the IgE Fc receptors on the mast cells. On the subsequent exposure to the allergen, mast cell degranulation occurs, which causes release of mediators like histamine and interleukin 5. Histamine causes bronchoconstriction, and interleukin 5 causes eosinophil recruitment. Some cytokines and chemokines can also stimulate the epithelial cells, which produce a potent chemoattractant known as eotaxin, which also causes eosinophil recruitment. Let us move on to the early or the immediate phase of an asthmatic reaction. It is dominated by bronchoconstriction and increased mucus production. As we can see here, the vagal afferent nerve here is giving signals which is stimulating increased vascular permeability, which results in edema. The vagal efferent nerve here carries signals which stimulates the smooth muscles to constrict, which causes bronchoconstriction. The late phase of an asthmatic reaction is dominated by inflammation. As we can see here, there are various eosinophils in the lamina propria layer and angiogenesis. The image to the left here shows a mucus cast spat out by a patient during a severe attack of asthma, also known as status asthmaticus. Now let us compare the normal airway of an individual to the airway of an asthmatic individual. Moving inside outwards, we can clearly see the airway of the asthmatic individual is blocked by mucus plug, present due to increased mucus production due to the goblet cell metaplasia in the epithelial layer. We can see below the basement membrane, the subbasement membrane fibrosis in light pinkish color. In the lamina propria, we can see numerous eosinophils and angiogenesis. We can also see smooth muscle hypertrophy and gland hyperplasia. Let's discuss the microscopic examination of asthma. This split image here shows on the left the airway of a non-asthmatic individual and on the right an airway of the asthmatic individual. As we can clearly see, the airway of the asthmatic individual is blocked due to increased mucus production, which is due to goblet cell metaplasia. We can see in bright pinkish color here the smooth muscle hypertrophy, and in light pinkish color just below the basement membrane, the subbasement membrane fibrosis. Zooming in on this image, we can clearly see here the dark red stained eosinophils as demarcated by the yellow arrow in the lamina propria. The green arrow here demarcates goblet cell metaplasia, the black arrow demarcates subbasement membrane fibrosis, and the blue arrow here demarcates smooth muscle hypertrophy. The microscopic examination of sputum of an asthmatic patient reveals characteristic features such as charcot-laden crystals, which are comprised of the protein galactine-10, and Kurzman spirals, which are formed of the shed epithelium. Moving on to the investigations performed for asthma. In a spirometric examination of an asthmatic patient, the peak expiratory flow rate, the forced expiratory volume in 1 second, and the FeV1 to forced vital capacity ratio is reduced and below the lower limit of normal. The radioallergosorbent test is also performed for asthma, which measures the level of IgE antibody in the serum, which is indicative of asthma. Here are some references used in this presentation. Thank you. Now I would like to call upon Palak Sharma of the Pharmacology department.
So while they are loading the next presentation, my suggestion to our young presenters is try and make eye contact with the audience. If you're looking at the slides, the projected slides, and reading from there, then it's difficult to make eye contact. So try and read the slides from your laptop, and then you can make eye contact with your audience, right? So you try it one time, look at the projected slides and read, and then look at the computer, intermittently look at your audience, and then present. And you will be able to appreciate yourself the difference in the effectivity of the two.
A very warm good morning to all the respected dignitaries, esteemed faculty members, and my dear fellow colleagues. Today, I, Palak Sharma, alongside Shamin Gupta, Niharika Agarwal, Swasti Singh, and Kushi Upadhyay, under the guidance of Dr. Anusha Vora Ma'am, Professor and Head, Department of Pharmacology, and the moderatorship of Dr. Vinay Kumar Gupta Sir, Assistant Professor, is here to present on the topic Pharmacological Management of Asthma. The anti-asthmatic drugs are divided into two groups, the quick-release medications and the control medications. In quick-release medication, there are bronchodilators used to treat the acute episodic attacks of asthma, which includes short-acting beta-2 agonist, antimuscarinic, and xanthine preparations. In the control medication, there are glucocorticoids, which are anti-inflammatory drugs, which includes corticosteroids, leukotriene antagonists, mast cell stabilizers, biological therapies, and long-acting beta-2 agonists. Now we further move on to the classification of the drugs. The drugs used in bronchial asthma are divided into three groups, the bronchodilators, anti-inflammatory, and the biological therapies. In bronchodilators, which are used to treat bronchospasm, there is adrenergic drugs divided into two, non-selective, which includes adrenaline, isoprenaline, selective beta-2 agonist, which has salbutamol, terbutaline, bembuterol, salmeterol, and formoterol. The next group is anticholinergic drug, which has ipratropium and tiotropium. The methylxanthine includes theophylline, aminophylline. The next group is the anti-inflammatory, which prevent bronchospasm, has corticosteroid divided into two. The inhalational consists of beclomethasone, budesonide, fluticasone, and flunisolide. The next is systemic, which has prednisolone, hydrocortisone. In the anti-leukotriene drugs, we have leukotriene synthesis inhibitors like xylitol, leukotriene receptor antagonists like montelukast and zafirlukast. The mast cell stabilizers, we have sodium chromoglycate and ketotifen. In the biological therapies, we have omalizumab, benralizumab, mepolizumab, risalizumab, and dupilumab. Now we further move on to the mechanism of the action. The first is the beta-2 agonist, which acts on the adenyl cyclase and increase the amount of cyclic AMP, which causes relaxation of the bronchial tone. The next we have the muscarinic antagonist, which inhibits the action of acetylcholine, which causes bronchoconstriction and lead to the relaxation of bronchial tone. The next we have the theophylline, which acts on the phosphodiesterase and inhibit the production, which increases the amount of cyclic AMP and which causes the relaxation of bronchial tone. The thiophylline also act on adenosine, which inhibit it and causes relaxation. The next is the leukotriene pathway inhibitors. The membrane phospholipids break into the arachidonic acid in the presence of phospholipase A2. The arachidonic acid further move on with the two pathways. In the presence of cyclooxygenase, it forms prostanoids, and in the presence of LOX, it forms leukotriene A4. The leukotriene A4 further divide into leukotriene B4, which causes leukocyte chemotaxis and mucose secretion. The leukotriene D4 and E4 causes bronchoconstriction. To reduce the bronchoconstriction, there are inhibitors like corticosteroid, which inhibit phospholipase A1 in the presence of protein annexin A1. And the next is the xylitol, which inhibits the LOX, which reduces the formation of leukotriene A4. And the last we have the montelukast and zafirlukast, which are receptor antagonists of leukotriene D4 and E4. Now we further see the detailed classification of the quick relief medication. The first is the short-acting beta-2 agonist. In short-acting, we have non-selective beta agonists. The drug included are epinephrine and isoprenaline. The clinical use of these drugs are they are potent bronchodilators, and the adrenaline is the drug of choice for the acute anaphylaxis. The pharmacokinetics of these drugs include they are given subcutaneously, not effective orally, and rapid onset of action, has a short duration of action. The adverse drug reactions are they cause hyperglycemia, skeletal muscle tremors, and the severe side effects include tachycardia, arrhythmia, and hypertension. These drugs are contraindicated in serious patients, diabetic patients, asthmatic patients with hypertension or heart failure. Selective beta-2 agonists are divided into two groups, the short-acting beta-2 agonist and the long-acting beta-2 agonist. The short-acting consists of salbutamol and terbutaline, and the long-acting consists of salmeterol and formoterol. All are given by inhalation routes. The clinical use of the short-acting beta-2 agonists, they are the drug of choice for acute episodic attacks of asthma, and the long-acting are not used to relieve the acute attacks but are used in the nocturnal asthma. The pharmacokinetics of the short-acting beta-2 agonist drugs have a rapid onset of action and a short duration of action. In the long, it has a long-acting bronchodilators. The advantages of these drugs are they have minimal serious effects and suitable for asthmatic patients with cardiovascular disorders. These drugs also causes the disadvantages like skeletal muscle tremors, nervousness, tolerance, and tachycardia. The next we have the muscarinic antagonist. The drug included are ipratropium and tiotropium. The duration of ipratropium is has a short action like 3 to 5 hours, and tiotropium have a long duration of action like 24 hours. The pharmacodynamics of these drugs are they inhibit bronchoconstriction and mucus secretion. The uses of these drugs are they are the main choice in COPD and in acute severe attacks of asthma. It is also combined with beta-2 agonist and corticosteroids. The pharmacokinetics, these are given by aerosol inhalation. The next we have the methylxanthines. The drug included are theophylline and aminophylline. The pharmacological effect of these drugs are they are bronchial muscle relaxation. They increase the contraction of diaphragm and improves ventilation. The serious effects include increase in heart rate, increase in force of contraction. The GIT includes gastric acid secretion. The kidney includes increase in renal blood flow. The overdose causes tremors, nervousness, insomnia, and convulsions. The theophylline is administered by oral routes, and aminophylline is given as slow infusion. The uses of these drugs are they are second-line drug in asthma. The side effects of these drugs include low therapeutic index. The GIT effects are nausea and vomiting. Serious effects are hypertension, arrhythmia, and the CNS side effects are tremors, nervousness, insomnia, and convulsions. The next we have the prophylactic therapy, which are anti-inflammatory drugs. The first is glucocorticoids, leukotriene antagonist, mast cell stabilizer, and anti-IgE monoclonal antibodies. Now we see the detailed description of the glucocorticoids. The pharmacological action of glucocorticoids are they are anti-inflammatory in nature, immunosuppressant effects, and have metabolic effects like hyperglycemia, increased potassium protein catabolism, and in mineralocorticoid effect, it increases potassium excretion, behavioral changes, and bone loss. They are administered by inhalational routes, have first-pass metabolism, and example like budesonide, fluticasone, and beclomethasone. Orally, they are prednisone, methylprednisolone, and injection by hydrocortisone and dexamethasone. The glucocorticoid in asthma are not bronchodilators. They reduce bronchial inflammation and reduce bronchial hyperactivity. The clinical use of these drugs are they are also used in the treatment of inflammatory disorders, treatment of autoimmune disorders, and antiemetics in cancer chemotherapy. The side effects of these are adrenal suppression, osteoporosis, susceptibility to infection, fluid retention, hyperglycemia, fat distribution, cataract, and psychosis. The side effects due to inhalation includes oropharyngeal candidiasis and dysphonia. They also have the withdrawal syndromes. The leukotriene antagonists, the drug included are zafirlukast, montelukast, and tranlukast. They are administered orally and are used in the prophylaxis of mild to moderate asthma, not effective in acute attacks of asthma, and can be combined with glucocorticoids. The side effect of these drugs are elevation of liver enzyme, headache, and dyspepsia. The mast cell stabilizers are chromoglycate and nedrocromyl. The mechanism of action of these drugs are they act by stabilization of mast cell membrane. The uses of these drugs are they are used in the prophylactic therapy of asthma in children and also used in allergic rhinitis and conjunctivitis. The pharmacodynamics, they are also not bronchodilators, so they are not effective in the acute attacks. They are prophylactic drugs which are used in the long-term treatment. They reduce bronchial hyperactivity and children respond better than adults. The side effect of these drugs are they are bitter in taste and minor upper respiratory tract irritations. The last we have the anti-IgE monoclonal antibodies. The drug included is omalizumab. The mechanism of action of these drugs is monoclonal antibody directed against IgE given by injection, prevents IgE binding with the receptor on the mast cells and basophils. The disadvantages of these drugs are they are expensive and not used as a first-line drug therapy. Their uses of these are they are used in the treatment of moderate to severe allergic asthma, which does not respond to high doses of corticosteroids. Now we have the other US FDA approved biological therapies like benralizumab, mepolizumab, and risalizumab, which are interleukin-5 receptor antagonists, and newer molecules in the clinical trial are RGEN 3500, tenzolizumab, and fevipiprant. There are GINA guidelines for the asthmatic management of the patient of different groups like 12 years and above, 6 to 11 years, 5 years and below, which perform the stepwise uses of the drug. Thank you.